Giant cell tumor. Giant cell tumor belongs to category of tumors of unknown origin. It is characterized by presence of numerous multinucleated osteoclast type giant cells and is also called osteoclastoma. So what they're trying to tell here is that multinucleated giant cells become abnormal in number. They have osteoclast like activity and hence they are also called as osteoclastoma. But this is a big misnomer because the giant cells and osteoclasts are not same. They just have osteoclast like activity. Although giant cell tumors are benign, they can be locally aggressive. Uncommon tumor usually arises in 3rd to 5th decades of life, that is between 30 to 50 years. Most cells within giant tumors are non-neoplastic, as we have discussed, osteoclasts and their precursors. The neoplastic cells are osteoblast precursors. Now, these osteoblast precursors are nothing but mononuclear stromal cells, which are derived from primitive mesenchymal stromal cells. So, these mononuclear stromal cells express high levels of rank L, which in turn promotes the proliferation of osteoclast precursors. So, what they're trying to tell us here is that this rank L actually binds to rank receptors present on monocyte or macrophage precursors, which are nothing but these osteoclast precursors only. Now, these cause differentiation into mature osteoclasts. Now, here the mature osteoclasts are nothing but the multinucleated giant cells. The absence of normal feedback between osteoblast and osteoclast results in localized but highly destructive bone resorption. Because these multinucleated giant cells become more in number, it has osteoclast like activity, bone resorption occurs. The neoplastic cells have acquired mutations in the gene encoding histone 3.3, a chromatin packaging gene. This is all not that much necessary, you can skip that. Giant cell tumors develop within epiphysis and may extend into the metaphysis. So the majority you can see near the knee, involving distal femur or proximal tibia. You can just remember distal femur or proximal tibia. But normally any type of bone can be involved. They arise near the joints. Giant cell tumors may cause arthritis-like symptoms. They can also present with pathological fractures. Pathological fractures are also seen in osteosarcoma. So, let's discuss morphology. Everything is not necessary, few points are important. Gross, the tumors are large, red-brown masses, they undergo cystic degeneration. Necrosis will be seen. Mitotic activity may be prominent because again these are tumors. So, important point, expansile lytic lesion, especially eccentric in epiphysis, because they have osteoclast like activity. They eat off the cortex or the bone. So, eccentric expansile lytic lesions are seen. Now, if you see this image clearly, these are multinucleated giant cells. I'm sorry, the nuclei are not clear, and the background has mononuclear stromal cells, which are osteoblast precursors. So, the clinical features, they can be treated because they have local invasion, but 4% metastatize into the lungs and they can regress spontaneously and they're fatal. The rank inhibitor denosumab, important, has shown promise to adjuvant therapy. Rank L inhibitor denosumab. And the important point you have to note here is that X-ray has soap bubble appearance. Soap bubble appearance, if it is given in your question paper or some as a clinical question, it will definitely show they'll be talking about the giant cell tumor. Thank you.